بسم الله الرحمن الرحيم. يعني this lecture will be as a film reading lecture to many entities. Just concentrate please and try to pick the findings before I get them out. Concentrate please and interact. This female patient, 60 years old, she's complaining of this abnormal uterine bleeding, not dysfunctional, it is an abnormal uterine bleeding. But they say that it's sporadic, come and go like staining only, and MRI was requested. In the ultrasound, they say that there is enlarged ovaries and uterus. This is the sagittal T2. Again, note here the uterus. Okay, we will try to get another sequences. This is axial T2. Again, this is the uterus. And what about the ovaries? T1. There is bulky ovaries as we see here. Again, along with the T2. Bulky ovaries. And here is the post-contrast. This is the bulky ovaries that we see taking homogeneous enhancement. And this is the uterus. It's so heterogeneous, although the endometrium is thin. Here also, this is the post-contrast also. Of course, there is another finding that you must pick. So the findings here is that the uterus is bulky for age. It's bulky for age, which is 60. It shows heterogeneous signal intensity with small sized fibroids. This is a fibroid and this is another fibroid. And here the endometrium is thin. It's not thick endometrium. The cervix here, there is also irregularity and maybe fibroid in the posterior lip, and this is the cervical canal. So there is no definite evidence of malignant lesion, in spite that the patient has irregular bleeding. The endometrium is average for the postmenopausal age group. The thickness was 4 millimeter here, and it is indented by these fibroids. And she has normal cervix, inner and outer stromal zones, and apart from these fibroids. When I always found abnormal feature in the MRI, I used to get the patient for second look ultrasound. This is a second look ultrasound. What gave the heterogeneity of the myometrium was these calcifications present. There are calcification, there is fibroids, and there is calcifications seen throughout the uterus, and this is normal dystrophic calcification that occur with the postmenopausal age group. Then came to the ovaries. We have also bilateral enlarged ovaries. They are homogeneous and they take homogeneous contrast enhancement. This is the T1 and this is the post contrast. It takes homogeneous contrast enhancement of benign nature. And this is the ultrasound picture. Here is the ovary. It's not vascular at all. There is no vascularity on color Doppler. You see that the ovary is homogeneous. There is no follicular activity and there is no vascularity on color Doppler. So that was our report. Bilateral bulky ovaries more on the right side and there is no intralesional vascularity. They elicit low signal في T1 وintermediate signal في T2. The uterus is bulky. However, there is no definite focal endometrial lesion. Heterogeneous signal, fibroids, no para-aortic lymphadenopathy, no mild free fluid, bowel wall thickening. And it was written as a fibrothecoma, estrogen producing. And you know that the estrogen producing fibrothecoma can cause troubles in the uterus and can cause dysfunctional uterine bleeding. But this is the uterus and this is the bilateral ovaries, and this is another thing which is more grave than our diagnosis at the first in the first setting. So this is bilateral enlarged ovaries that we thought to be benign in nature, and we have uterus and we refer to the ovaries in doing this abnormal uterine bleeding, but still we have more grave lesion here. There is circumferential thickening of the sigmoid, of the rectosigmoid region. There is circumferential enhancing lesion taking all the rectosigmoid. On requesting the patient and asking more, she has constipation, but thought that constipation with age no problem, but it was problem that she has a malignant lesion at the rectosigmoid, and so a biopsy was taken and colonic adenocarcinoma was the diagnosis. So in the first setting we missed this grave diagnosis, so don't be distracted by the patient history or by a pathology rather than the other. You have to look for all organs present in the pelvis, not only the uterus and ovaries. You have urinary bladder, you have rectum, you have peritoneum, you have many of the anatomical locations that can give pathology. So what about the ovaries? When we see that there is a malignant lesion, the first rush to that it could be malignant Krukenberg, metastatic. What is the Krukenberg tumor? Krukenberg, it is metastatic signet ring cell adenocarcinoma of the ovary. It is uncommon. It occurs in 5 to 10% of all ovarian tumors, and 80% is bilateral in origin. In 80% it is bilateral. But if it is not unilateral, it does not exclude Krukenberg. So in 80% it is bilateral, but in 20% it could be unilateral. They can originate from the stomach cancer, signet ring cells, most common. Colorectal cancer is the second most common. Breast cancer, lung cancer from contralateral ovarian carcinoma. It may be bilateral or contralateral ovarian carcinoma giving to the other side. Pancreatic carcinoma, cholangiocarcinoma, and gallbladder carcinoma. So we have here the second most common, which is the colorectal cancer. But is the features that we see, is that a picture of Krukenberg? I think not. Krukenberg seen sonographically as bilateral solid ovarian masses with clear, well-defined margins. A regular hypoechoic solid pattern, moth-eaten-like cysts may be seen on ultrasound. Here is bilateral Krukenberg tumor, and we have here a stomach cancer. CT appearance may be indistinguishable from the primary ovarian carcinoma. Features will favor towards a Krukenberg tumor if a concurrent gastric or colic mural lesion is seen. Tumors originating from the stomach may be denser on post-contrast CT because they are mucinous. So those originating from the stomach are more dense on CT than those coming from the colon. Krokenberg MRI may demonstrate more distinctive features on MRI, bilateral complex masses with hypointense solid component, dense stromal reaction, internal hyperintensity may be mucin. There may be mucin that is seen in T1 and T2, so it may be slightly hyperintense on T1 due to the presence of mucin, and there is a strong contrast enhancement seen in the solid component or in the wall of the tumoral cyst, which is again not the features seen in our case. It is homogeneous and there is no marked enhancement. It is enhancement of benign character. So again, we are in a debate. Of course, it will not affect the management of the patient. In this case, 60 years old, they can do panhysterectomy together with the colonic resection. But sometimes we have to look on the morphology of the MRI and on the functional characteristics of the MRI regarding the restriction, regarding, of course, the fibrothecoma can be restricted if it is cellular, and the dynamic post-contrast study. I have another case. She's also 60 years old. Our case is geriatric age. I think it's very obvious. The findings here are very obvious. Any one of you can pick them. Note here, this is the uterus. And we have bilateral adnexal masses with solid component and cystic component with malignancy. And here we have thickened endometrium and passing to the cervix. Cervical versus endometrial is another question. And here is the coronal MRI. Note here there is marked thinning of the cervical annulus, appearing as if it may be cervical cancer more than endometrial. Most of the epicenter of the mass in the cervix, but also extending to the endometrium. But on post-contrast, the solid components on the ovary is enhancing, of course, and the septum, and also the mass here take delayed enhancement, not early enhancement, and this may be more with endometrial carcinoma. But in these large cases, it's no problem to see if it is which is the first. Is it cervical extending to the endometrium or endometrial extending to the cervix? And we have also another grave pathology that we have bilateral malignant ovarian masses. Typical malignant ovarian masses, solid and cystic components, thick septi, enhancement for post-contrast. And this is the ultrasound picture. Again, here we can see the picture Guyrat's 5. This is Guyrat's 5, where we can see solid components, cystic component. We see here the heterogeneous endometrium in the uterus. So again, the ultrasound is with malignant ovarian lesions, and this is the heterogeneous endometrium and passing to the cervix. So again here we have, this is, no, there is no early enhancement. So this is with endometrial more than cervical. And then here we have bilateral ovarian masses. So here we have a dilemma. Many times we found endometrial and ovarian cancer at the same time. We have both endometrial and ovarian cancer. What is your differential diagnosis? Synchronous endometrial and ovarian cancer have been reported in 5 to 10% of endometrial and ovarian cancer. And by our time here, we can see that many of the hereditary cancers are now too much. We can see GIT with ovarian, and we can see endometrial with ovarian. So it can occur synchronous in 5 to 10% of cases. But still, 5 to 10% is the rarest entity. Gynecological cancer shows a predilection to loco-regional metastasis. Any gynecological cancer can give to each other, and it's especially true for ovarian cancer. And ovarian cancer can give the endometrium and cervical, and also vaginal metastasis. We have a case, we report a case of vaginal metastasis in case of bilateral malignant ovarian lesion in a pregnant female. It is on the British Journal of Radiology. Synchronous endometrial, endometrioid, endometrial and ovarian. We have synchronous endometrioid. Endometrioid carcinoma is one of the epithelial ovarian tumors. It can affect both the endometrium and the ovary at the same time. And enlarged ovaries and thickened endometrium can help predict the possibility also of estrogen producing ovarian tumors, especially in the premenarchal age. They go with precocious puberty, and in the postmenopausal age group, they come with abnormal uterine bleeding. It is important to pay attention to uterine configuration when diagnosing ovarian tumors. The most common that they are estrogen secreting producing tumors are the thecomas and the granulosa cell tumors. This is another case, female 60 years old with postmenopausal bleeding. I think these cases you can find on the group if you fetch for them, but I try to get them in order to make a case-based review on. Of course, in this case, the first possibility you all will say that it may be malignant lesion. And I think one of the colleagues reported that it may be cervical carcinoma. No, it's not. And I have another lecture on the intracavitary uterine lesions, and this is one of the intracavitary uterine lesions. It is only distending the cervical canal, but it is not arising from it. Here on T2, it is arising, the Broccoli sign, I say in the intracavitary lesions, this is the Broccoli sign. Here, this is a large polyp arising from the wall of the uterus, and it shows cystic changes, so it's more towards a polyp. Although in this age group we could not exclude malignancy, but this is a polyp and not cervical cancer, and not endometrial and passing to the cervix. No, it is a polypoidal lesion that arises from the anterior wall of the uterus with a pedicle and passes to the cervix. This is the axial. This is the polyp. It shows areas of hemorrhage within, bright on T1. But what is this? There is another pathology. So this one, which makes the complaint of the patient, she has bleeding. It's arising from here and coming down, distending the cervical canal, but the cervical wall is normal. But what the hell is this? There is another adnexal lesion. There is another adnexal lesion present in the left adnexa. So again, you must look in all the area, not only to the pathology you have seen at first look. So we have an adnexal lesion, this is in T1, and on T2 here, this is the post-contrast. Oh, this is the post-contrast. It takes contrast enhancement. Looks synchronous on the T1 and on the T2. It is hypo-intense here, and on the post-contrast, it takes homogeneous post-contrast enhancement with cystic area also present in the periphery of it. Again, to the other dilemma, we have adnexal lesion with uterine lesion. Here, the coronal. This is the polyp, Brockley sign. And here, there is an adnexal solid and cystic lesion, but a cystic lesion appears as if it's in the periphery of it. But it's mainly a solid mass enhancing on post-contrast. So we have a polypoidal lesion with cystic changes. I am with that it is towards benignity rather than malignancy because it does not infiltrate, although it has hemorrhagic cystic changes within. And then we have this adnexal mass with peripheral cystic lesion, and it is homogeneous on post-contrast. On the morphological features, it appears solid, and on the functional features of MRI, it takes homogeneous contrast enhancement. Note the enhancement regarding the myometrium and regarding the mass. It is nearly the same. So it is faint homogeneous enhancement in the delayed phase. So again, it's not so with malignancy. And that was her pathology. Regarding the endometrium, the examination of the endometrial polyp revealed the picture of hyperplastic endometrial polyp with hemorrhage and necrosis, no malignancy. Regarding the left ovarian mass, it reveals benign growth formed of bland spindle cell with foci of luteinization, and it is with leutomas, or here we can say that it may be with benign lesion, here with benign lesion, and she has benign peritubal cyst on the right side we could not see on the imaging. So this was fitting with our imaging findings that the left ovarian mass is with benign nature. But of course, in this age group, they usually do hysterectomy, pan-hysterectomy. So it will not a so problem here. They say that they do hysterectomy, but sometimes if she's younger than that, and you say that it is towards benignity, they will be more conservative. They can remove only the polyp and remove the adnexal mass and preserve the uterus for this lady. Bilateral ovarian enlargement. We have many cases of bilateral ovarian enlargement. Bilateral ovarian enlargement may reflect benign or malignant processes of the ovary. So take home message, ultrasound remain the first imaging modality. You must exhaust it first. And here you must also search about lymph nodes. You must do dynamic post-contrast in MRI and diffusion post-contrast. Another case, she's 40 years old, and we grow with the childbearing age group. 40 years, complaining of lower abdominal pain, and the examination, they found a blind vaginal pouch, and the patient was married. She said she has regular menses every month. And that was her MRI. This is the ovary. And here, this is the uterus. There is a cystic lesion present within the cervix, inside the cervix. And then we could not see a proper vagina. We could not see a proper vagina. Here, we could not see a proper vagina. We're just a vaginal pouch here. We have seen just a vaginal pouch. And here, the cystic lesion is not coming. So it was very, especially this patient was 40 years old. I think I put it in the cases of urogenital sinus syndrome, and this is was a case of urogenital sinus syndrome. This is the ovaries, and this is the cystic lesion. It appeared proteinaceous, not hemorrhagic. So I think it is just an Apothean follicle distending the cervix, and we could not see the communication well. This is the uterus, and this is the cystic lesion by ultrasound inside the cervix. Here this is transvaginal, but we get from the pouch, but we could not reach more than that. So still we could not know the communication well. Here by ultrasound we see that the vagina is traversing with the urethra, so it is a case of urogenital sinus syndrome. Although the patient is 40 years, we are with congenital. Just a hint here that the proper technique is very important. When we found a case of urogenital sinus syndrome, you have to do pelvic floor protocol with cine imaging in order to see the case. Here, this is the vaginal pouch. It's not communicating above. And this is the urethra. And then here, this is micturating film. Here, this is the urethra. Can go through. This is the urethra. And here is the vagina. We inject gel inside. And this is the confluence of the urogenital sinus syndrome. This is the opening of the cervix in the urethra. So this is an upper confluence. We have upper confluence and lower confluence. It is here opening near the upper end of the urethra, not near the lower end. And the patient was living well, and there is no problem. She gets her menses from the urethra, but there is no infection because I think it's below the bladder neck. So this is a case of urogenital sinus syndrome. We get it before. This is the vaginal pouch and the lower end. And this is the urogenital sinus. We have a lecture on the urogenital sinus syndrome, so we'll pass it. This is the genotography. We used to do it in Abu Rish Hospital, where we can see the confluence between the urethra and the vagina. They have common opening. So again, we should have transperineal ultrasound in order to see this obstructing lesions. This is another case. I don't know you see before with me or not, but she's 43 years old female with vaginal bleeding, and here there is what? There is a cervical mass. There is a cervical mass. Okay. Here is the uterus. This is the uterus, and this is the cervix. This is an endophytic growth of the cervix. Here there is no cervical wall present. It is engulfing most of the cervical wall. Okay. This is the post-contrast. As cervical carcinoma, taking the picture is differing from the case of the polyp. Here it is a growth of the cervix engulfing most of the cervical wall, and there is ballooning of the rest of the cervix. I think there is a sort of cervical stenosis at the external os causing this distended fluid. And then we came to the staging. This is the T2. Here we see the cervical mass. There is the ovary, and there is parametrial infiltration. There is marked thinning of the cervical stroma. And here, note here, this is the annulus of the cervix. And in the annulus of the cervix, this part is there is loss of the annulus of the cervix in this part, so there is parametrial infiltration. This is the appearance of parametrial infiltration. So if we stick to this part, it will be stage 2A, 2B. This will stage 2B. But again, there is another findings. Here, what we have here, we have MS in the left adnexal region, and we have, here we have MS, and we have the typical dilated serpiginous fallopian tube dilated. Here also, this is a dilated fallopian tube, and MS in the adnexal region also. Here, this is the dilated fallopian tube, and we have multiple, there is a mass here, and we have a large mass here. Usually, this mass have the same characteristic of the original mass present in the cervix. So this is a lymph node. This is a large lymph node present in the adnexal region, and there is also metastasis in the fallopian tube, and this is what we have just tell from a while, that the genital organs can give to each other. So this is a metastasis to the fallopian tube from the cervical carcinoma. This is metastasis to the fallopian tube. So when you find complex lesion in the adnexal, in the case of cervical carcinoma or endometrial carcinoma, usually think that it may be fallopian tube metastasis. Here, this is fallopian tube metastasis. Multiple lymph nodes are also seen in the adnexal region. Large lymph node. This is one, and this is another one. This is picture of lymph nodes. On diffusion, it is restricted on diffusion weighted images, and this is because it's malignancy. And also there is restriction in the adnexal part. This is fusion imaging showing the endometrial, the cervical carcinoma extending to the lower uterine, on the endometrium and in the lower uterine segment. So this case show many of the stages that you can see in cervical cancer. So what is about the adnexal region? This is a lymph node seen also by ultrasound. This is a lymph node, and this is another lymph node, and also we have tubal metastasis present, and this is the fallopian tube, which show vascular lesion inside. By ultrasound, this is a tubal metastasis. So this is the lymph nodes. So the fallopian tubes is usually a missed organ of the genital organs. We didn't look at it because usually the fallopian tube may contain masses. What are the masses that may be seen in the fallopian tubes? This case is cervical cancer stage 2, it's 3C, 3C1. This case is a stage 3C1 because it has lymph node also. Okay, what about the fallopian tube mass? Fallopian tube mass. Fallopian tube masses comprises 0.3% of all gynecological cancers. Usually it is secondary. Because as causing Krukenberg tumor on the ovary, it causes metastasis within the fallopian tube. Tubal involvement often by ovarian borderline tumors, by carcinoma, cervical, endometrial carcinoma, and pseudomyxoma pretonii, and may also occur due to extragenital site origin. Stomach, colon, as in cases of Krukenberg that we have just said. Is that a similar case? No, it is not a similar case because we have preserved cervical wall. Note here, the cervix is preserved. And this mass is pedunculated intracavitary mass. There is a pedicle here, Broccoli sign. There is a pedicle here coming from the lower uterine segment or from the cervicocorporeal junction. and the cervical wall is intact and it is prolapsing from the external os. So this is a fibroid. This is a fibroid. So this is another intracavitary lesion that it is not malignant, it is a fibroid. This homogeneous enhancement on post-contrast study. So this is a fibroid, prolapsing fibroid from the cervix. Pedunculated, prolapsing fibroid. So not all cervical mass is cancer. You have to look to the cervical wall better, see the morphological features and the functional imaging of the MRI. This is 50 years old virgin presenting by purulent vaginal discharge and abdominal pain. That was her ultrasound first. Enlarged uterus. Here we can see this. What is this? This is just speckling of air. It's air. This is speckled artifact. This is air inside. When you find air inside, then we are talking about infection. So this is air inside the uterine cavity. Okay, pyometra. And this is the adnexal region, and here there is a solid component present inside. There is air. There is air here. But there here is a solid mass with vascularity. So again, Doppler is mandatory in these cases in order to exclude that it is infection superimposed on malignant lesion. There is a malignant lesion with superimposed infection on. And this is her MRI appearance. Here, this is a fluid level, air fluid level present. Air fluid level present. Heterogeneous myometrium, dirty myometrium. حتى even the cervix is irregular in shape. So this is pyometra, but here there is enhancing solid mass present in the lower uterine segment. There is enhancing solid mass present in the lower uterine segment. So again, contrast is very important, and always especially this case was virgin. When you find a virgin with infection, where is coming from? Most likely it is secondary to tumor present. And here is the irregularity seen above of the pyometra present and fluid level air. So it is neoplastic and the inflammatory on top. Neoplastic and inflammatory on top, and that was her pathology. We know the irregular endometrium and the shreds present in the malignant mass. So this is endometrial carcinoma with pyometra on top. Endometrial carcinoma with pyometra on top. Pyometra is a rare disorder with reported incidence of 0.01 to 0.5% of gynecological patients. It is more common in elderly and postmenopausal women, usually with concurrent medical conditions. It is a serious medical condition because it is associated with malignant disease in many cases, and there is danger of a spontaneous perforation, which is with high incidence of mortality in it. It is collection of pus. Pyometra also can occur due to stenotic lesion in the cervix, not only malignancy. There may be following radiotherapy, fibroid degeneration, cervical occlusion following surgery, senile cervicitis, puerperal infection. Of course, in the childbearing age, we should think of puerperal infection or post-abortion. Congenital cervical anomalies and forgotten IUD. Sometimes patient, even postmenopausal, they forgot her IUD and maybe she's diabetic or something, and pyometra occur on top. Genital TB also should be put in the differential diagnosis, and any of the assisted reproduction can cause biometer. Okay, this is obstetric, but we can take it كده for fun. This is a case here. This is the head, and this is the femur. I think we saw it before on the group. And this is the striking feature here is what? That there is no bone. Here there is no bone in the skull. The debris of the skull, there's not the density of the bone of the skull. And the femur is below the second percentile, and it is curved like the telephone handle. So we have here dysplasia, short femur equal dysplasia. Dysplasia with normal bone ossification or dysplasia with low bone ossification, this is important. So this is dysplasia with low bone ossification. And then there is this, there is important feature here that we have blood inside the ventricle. We have blood inside the ventricle here. There is blood inside the ventricle. So she's poor fetus. There was ascites also. But the hallmark of the exam here that we have short femur below the second percentile, but the other measures are within normal. But we have low femur. So this is the hallmark of the cases of dysplasia. This is the 4D of the case. And here there's short limbs, short limb dwarfism. And we have here, why the video is not working. We have the brain apparent within the skull here, with the protuberant abdomen due to the presence of ascites. What we can say is short femur, okay, equals skeletal dysplasia. In this case, is it lethal dysplasia, bone softening dysplasia, rare estimated incidence of this case, all of the above or none of the above. I think it is all of the above. It is a lethal dysplasia with bone softening and rare estimated incidence, and that is this is the bone softening, and this is the femur, and this is the post-abortion X-ray. There is no skull bones. There is no skull bones. Even the femur and the spine are of low ossification. So it is a case of achondrogenesis type 1A, and this is a case from the literature post-abortion. Achondrogenesis is a number of disorders that are the most severe form of congenital chondrodysplasia. It is the severe form of congenital chondrodysplasia. We have malformations of bone and cartilage. An estimated incidence 1 per 4,000. So it's very a rare recognized entity. There is no gender predilection. And these conditions are characterized by small body, short limbs, and other skeletal abnormalities. What is the differential diagnosis of the bone non-ossifying bone dysplasia? Severe cases of hypochondrogenesis may present with micromelia, unossified vertical, sacral, and vertebral bodies. Severe congenital hypophosphatasia, characterized by diffuse mineralization defect with irregularly ossified skeleton, micromelia, and multiple fractures. Osteogenesis imperfecta type 2 can present with absent calvarial ossification, multiple fractures, micromelia, but all the segments of the spine are ossified. And in xenophoric dysplasia, there is good ossification. It is one of the differential diagnoses, but it has good ossification of the skeleton. But we have short limbs, hypoplastic thorax, or shaped ribs, and this is the characteristics of the xenophoric dysplasia. Accurate antenatal diagnosis of skeletal dysplasia is proclimatic. The most common predictors of lethal skeletal dysplasia include early and severe shortening of the long bones. Early and severe shortening of the long bones, femur length to abdominal circumference ratio less than 0.16. This is a form, the form of severe skeletal dysplasia, and also the presence of hypoplastic thorax. The presence of hypoplastic thorax. This is the heart, even there is no lung at all. And this is the abdomen, and there is a hypoplasia, hypoplastic thorax. This is one of the grave features of the skeletal dysplasia. Note here, this is the hypoplastic thorax, lung hypoplasia. This is okay. What's wrong also with this fetus? Well, there is cystic lesion related to the neck, but the video is not working. Okay. So this lesion is related to the neck of this nice baby, but unfortunately it is a grave condition sometimes. So it is a mass or cystic lesion related to the neck. Also, of course, it may be a part of cystic hygroma, but in this case it was isolated to the neck of the fetus. Isolated to the neck of the fetus. What is cystic hygroma? It is a cyst or a group of cysts found mostly in the neck, and they are caused by an error of development of the lymph sacs. There is an error of development of the lymph sacs of the fetus. Cystic hygroma, they occur most commonly in the neck, and it is termed nuchal cystic hygroma, and occurring in 80% of cases, in the axilla sometimes, and in 10% of cases it may extend to the mediastinum, and in 1% it is confined to the chest. What are the associations with cystic hygroma? Many associated anomalies are associated with cystic hygroma, mainly aneuploidic anomalies, Turner syndrome more frequently, Down syndrome, second most common aneuploidic association, and then trisomy 13, trisomy 18, and triploidy. The non-aneuploidic is with the congenital cardiac anomaly. This is another case, but I don't know this, they are not working. This is another case of cystic hygroma in the neck, but in this case the full fetus have there was anomaly, and it is non-immune hydrops fetalis. There is pleural effusion, and here the lung is the heart show single ventricle and single atria. Videos are not working. Okay. On prenatal ultrasound, they may present with nuchal cyst or show fetal anasarca or hydrops fetalis. Presence of septations within the cystic hygroma may indicate poor outcome. The presence of septations indicate poor outcome, and the greater volume, more than 75 cubic millimeter, are thought to correlate with increased karyotype abnormality and more unfortunate fetal outcome. Okay, another case. We have here the uterus. What is this? This is a hemorrhagic lesion present, but it is related to the uterus. There is no typical claw sign, but it is inseparable from the uterus. Of course, first we thought that it could be a hemorrhagic cyst, but here we can see both ovaries. So it is related to the anterior wall of the uterus, the first. And then we have here the ovary, and this is the other ovary. So it is not related to the ovaries. I think here maybe there is a claw sign, a small claw sign here. يبقى هي hemorrhagic or fluid. It is a hemorrhagic lesion. And then came the ultrasound to solve the problem. There is a pedicle, not seen well on MRI. There is a pedicle between the uterus and this hemorrhagic cyst. And this patient was coming with pelvic pain. So this is a torsion of a small subserous fibroid, making it hemorrhagic as we see in the MRI. So this is a pedunculated, degenerated hemorrhagic fibroid. Just a hint here, this patient has massive ascites. Note here the uterus is small, low down. And here, this is a postmenopausal woman also. And here the ovaries are seen, they are relatively bulky. They are relatively bulky. Here the ovary. And on post contrast, note here those ovaries are adherent to the wall of the pelvis here. And this is with Krukenberg tumor also. Bulky ovaries with solid component, and they are adherent to, although they are not so much affected, so they are adherent to the pelvis here. They are adherent to the pelvis and they take enhancement, but there is no full-blown picture of Krukenberg tumor. So a finding also that in Krukenberg, usually there is ascites. In cases of Krukenberg, usually there is ascites. If there is no ascites and you find two lesions, sometimes colonic, as we see in the case, in the first case, that we have ovarian lesion and colonic lesion, but there is no ascites at all, and the ovarian lesion has benign nature, should think that it may not be Krukenberg tumor. Here, this is the ovary adherent to the wall of the pelvis and taking enhancement and rather bulky for age. So this is a Krukenberg tumor. Thank you for listening, and I think it will be helpful cases to you in your practice.